called the Charcot's triad. You have obstructive jaundice, biliary colic, and ascending cholangitis. And we've just told you how dangerous this condition of ascending cholangitis is. So it's called the Charcot's intermediate hepatic triad. Charcot, incidentally, was a Parisian physician who lent his name to a number of things. And the symptoms are high temperature with rigors, pain, itching, and jaundice. The pain is upper abdomen, may even radiate through to the back. So now you have gallstones. How do you predict? What is the risk stratification? And I think the best has been given in Blumgardt's surgery of liver, pancreas, and biliary tract. So bilirubin more than 2 milligrams per deciliter, alk phos more than 150, a present or a recent history of jaundice or pancreatitis, and dilated CBD with stone. You know, the sonologist might be good enough to have actually demonstrated a stone on sonography. And here is where you would go in for a pre-op MRCP plus minus ERCP. Now, just one issue. In your examination, if your examiner says that my sonologist has shown a stone, you may proceed directly to an ERCP. If there has not been, in the presence of just a dilated CBD, it might be sensible to do a medico-legally correct to do an MRCP before proceeding for an ERCP. Why is that? Why is that? Because some out here would actually develop a thing called post, yes, ERCP pancreatitis, and that can be absolutely deadly. So you don't want to get hauled up medico-legally. Okay.
Sir, in this case, can we go for endoscopic ultrasonography for evaluating CBD?
Yes, of course you can. Of course you can.
So is there any
MRCP? No, okay. It depends on what your facilities are. It depends on what your facilities are. If you have a very, very good gastroenterologist, you see, the gastroenterologist needs to straddle two lines. What does he need to do? He needs to be competent at gastroenterology, and he also needs to be competent at radiology. That's an unusual combination, which is why MRCP might be one of the options. Otherwise, you can do an MRCP. Can you tell me somewhere where it is mandatory to do an endoscopic ultrasound rather than an MRCP? I need one reason where you would actually opt for an endoscopic ultrasound and not an MRCP. So we will not do an MRCP. We will do a endo US. Where?
If the patient is on PPI, which is not compatible.
Not with PPI, no. What does MRCP do? Where is which
have any implant?
Implant, particularly
I'll just come in over here. Guys, please switch off your mic. A lot of ambient noise comes over here.
Yeah.
Please do
okay.
That. Thank you.
Particularly when you've had metallic implants, where in particular, let's suppose this patient had, like Smita, you know, somebody called Smita Patel, the lady who was a brilliant actress, died. She died of a leaking aneurysm, cerebral aneurysm. Where you've had a clip put on, you will not expose this patient to an MRCP. Where the patient has a pacemaker which is not MRI compatible, you will not expose this patient to an MRCP. Where some people, you know, if you've got a metallic heart valve, you will not expose this patient to an MRCP. So any patient with vital non-MR compatible metallic implants have to go in for an endoscopic ultrasound in preference to an MRCP. Will you remember that?
Yes,
okay.
Sir. Thank you, sir.
Okay. Intermediate, bilirubin 1.5 to 2 milligrams per deciliter, alk phos 110 to 150 units per liter, transaminases more than 2 times normal, and a remote history of jaundice or pancreatitis. Blumgardt's suggestion was here is an option for going in for an per-operative, intraoperative cholangiogram. Okay, that. Okay. Now, some people will come to you without any of these features whatsoever. And there you would go in for, if the patient has a normal liver function, no ductal dilatation, no jaundice or pancreatitis, you go straight forward for a cholecystectomy. They used to be at one point in time when we were in the process of transferring over from open cholecystectomy to laparoscopic. What we used to do, we were told when we were doing open cholecystectomy, when I grew up in the age of open cholecystectomy, that you have to do an intraoperative cholangiogram because that facility that saves you from causing bile duct injury. Now, there's been an extensive trial after laparoscopy came out. In the initial part, we were having horrendous liver bile duct injuries before, we were all in the learning phase. And there it was suggested that you do an intraoperative cholangiogram. But I think recently there have been a lot of randomized controlled trials which have said that it is probably not useful. I think Rudrajit, would you, and Ramanuj, would you agree with that? Anyway, that is the present thing. Okay, now that is
Sir, I didn't catch your question. Sorry, sir.
Role of intraoperative cholangiogram in a low risk patient. For a person who's going in for lap cholecystectomy, is it needed?
No, sir.
See, that is the thing. We have had plenty of trials and they've said that it's actually not necessary. Isn't it?
Yes, sir.
Okay. Now, I'm going to bring you to, this is an ultrasound scan. Now, we've been made, there was previously a painter called Dali, Salvador Dali, and he used to paint weird pictures. Now, the bile duct and the portal vein are like double barrels. This is the bile duct. Okay. And let me choose this color for the portal vein. The portal vein was that big. So usually you had, let's say, a 5 millimeter bile duct and the portal vein was 12. So that is the normal ratio. The problem is that even if the ultrasonologist doesn't show a stone, if this were to reverse, if this becomes bigger than the portal vein, then you've got a major chance of there being a common bile duct stone. Now I'm going to draw this out here. That is the bile duct. That is the diameter of the bile duct. Forget the stone that you see out there. And here is the diameter of the portal vein. You see the ratio has been reversed, hasn't it? The moment you have something like this, you must accept that there's a chance of there being a stone inside the bile duct, and which is very beautifully shown out here. Can you see that? Okay. The sonologist has been kind enough to show that for you. Okay. So there you are. Now, given that if you didn't have that, if you're given that, some of your examiners might be prepared to go in for an ERCP, sphincterotomy, stone removal, and putting in a stent. And then you proceed on for a cholecystectomy. Here, what we did was, we got this patient. Need to mute our phones, please. Okay, so this MRCP, and Dr. Rudrajit Sinha has already been through it, so I'm not going to spend too much of time out here, but except to tell you that that is the stone in the bile duct. So what you would do is do an ERCP, get the stone. The radiologist, the gastroenterologist would do a sphincterotomy, put in a Dormia basket, take that stone out, do a post cleaning sweep with a balloon, do an X-ray to confirm that the stone is all out, put in a stent, and then refer this patient to you for a cholecystectomy. But, and this is exactly what is being happening. You are doing an ERCP, sphincterotomy, and a stone removal out here. Now, sometimes life is not all that simple. This is an MRCP. And what do you see? You see multiple stones, faceted stones in the bile duct, and multiple stones in the bile duct as well. Faceted stones out here and faceted stones out here. So what are you going to do? I need somebody to tell me what you're going to do.
Sir, CBD exploration.
Sir, CBD exploration and drainage along with the open cholecystectomy.
Okay, so
Drainage
that
procedure.
Yeah, fair enough. So we've had multiple stones out here. So you could, if facilities exist, and when you're answering this as an examination, you must say this, that I come from a center, sir, where people do laparoscopic exploration of the bile duct. We will do this exploration of the bile duct and do a cholecystectomy and get out. Now, what are the things that you have to make sure that you have when you're doing a exploration of the bile duct? There's some things that you need to have with you, and these stones are multiple, so you need to be sure that you manage to clear out all the stones. How do you ensure that?
Intraoperative cholangiography.
Yeah, you do an intraoperative cholangiogram. So what you do is, before you take the gallbladder out, you cannulate the duct. If you're doing it laparoscopically, that's fine. And we'll have pictures to show that. You do an intraoperative cholangiogram and you've seen the stones. But that doesn't help you. You've explored the bile duct. And there are two ways you can explore the bile duct. If you have a single stone and a wide cystic duct, you can do it transcystic. So you can go through the cystic duct and take that stone out. Or in a situation like this, you would almost certainly do it through the duct. You will do that. You will make an incision, and the incision is almost always, not always, it's always longitudinal. Can somebody tell me why?
Here the goes through the 3 o'clock and 9 o'clock position.
Blood
Yeah,
supply
yeah,
at 3
so the blood supply.
3 and 9.
If you
3 and 9 o'clock.
If you remember my picture, I did the vascularity of the bile duct. There's one at 3 o'clock, one at 9 o'clock position. Together with which, don't forget that I also showed you Strasberg's demonstration of a Hyler branch as well. Okay, so remember that, which is the reason that I'm going to do a longitudinal exploration of the bile duct. We do a longitudinal cut, we flush the bile duct out. Now you need to make sure that you've walked in doing it laparoscopically or open, either way. Now, how can you ensure that you've taken the stones out, all of them? So you're going to need something like this. What is this?
Choledocoscope.
You're going to need a choledoscope if your situation is very, if your institute is very, you're going to need a Fogarty catheter. Yes, you're going to put in a Fogarty catheter, inflate the balloon and take it out. Now, normally when you use Fogarty, Fogarty is used for what? Fogarty. What is Fogarty used for? Absolutely. So Fogarty is, the balloon is very soft. So I have used Fogarty, and what happens is when you're using a Fogarty, the balloon ruptures, and that is a tremendous loss, which is quite an expensive thing. So what I have used is, I often use a size 10, or I have used a size 10 Foley catheter. Okay, so you use a pediatric Foley catheter, you put it in, inflate the balloon, and you drag it out. So that is a balloon. Or the other thing you can use is use the balloons that your radiologist, your endoscopic friend would use. That balloon is still far more resilient than a Fogarty. Okay, so now this also has one advantage. If you're using a Foley catheter, you've put the balloon out here, and you inject dye, make sure that that is clear. Again, you put it up, inflate the balloon, push dye, and then ensure that that is clear. Having done that, what would you do? You would close the bile duct after completing the cholecystectomy. Now, how would you close the bile duct? They're basically, in an examination, you might land up, your examiner might be very fond of putting in a T tube. So if your institute is used to complete closure, and for complete closure, you need either that Fogarty type balloon or you need the choledocoscope to make sure that you've cleared it out completely. Okay, so you've got a choledocoscope and you've cleared out the bile duct, or you've put in the Fogarty, cleared out the bile duct. You're 100, not 100%, you're 200% sure that you haven't left a stone in the bile duct. Then you can close up that cut longitudinally. Some people would actually do something. They would put in something like a stent, which can be removed later. They put in a stent, a double J stent, which has one J out here, the other J out here. Close that, uh, close that cut that you've made in the bile duct. And the way you would do it, you would use interrupted monofilament sutures. You would use something like PDS. You would use PDS to close up the bile duct. And the only problem with PDS is that it doesn't knot very well, so you have to be careful about that. The other option is to put in a T tube. When you put in a T tube, you put in the T tube, the longitudinal tube comes in out here, and you put in the transverse tube out there. Now there's a way that you prepare that longitudinal. It comes as a T complete. It comes like that, and this is complete, and that is complete. So what you do is you take a scissors and you would actually cut that part. So now you have a slit. This is open on both sides. The reason for doing that is that you don't want the tube hinging and causing a damage to the bile duct when you're going to yank it out after, let's say, 10 to 14 days. Now, the other issue, that is the other cut end. Okay. Some people also make a small wedge out here. Right. So when do you remove the T tube is the other question. If you're putting in a T tube, almost certainly your examiner is going to ask you, where do you put in the stitches? The usual dictum is you put in the stitches on the top. And the important thing is don't put in a knot at the bite, leave it open so that it fits. If to put in that last bite and ensure that you haven't taken a bite into the tube, that can be disastrous if your PDS has gone into the Ryle's tube. So what you need to do is ensure don't tie up the ones that the last few stitches, leave it open, take a very snug bite and then tie it up. Okay. When do you remove the T tube? When we were young, we were given T tubes made of rubber, latex. And that generated an enormous amount of fibrosis. Most of the Romson's T tube don't. So you have to wait an appropriate period of time because you want that fistula tract to form. Okay. The idea is you wait for 10 to 14 days, then you clamp the T tube, make sure that the patient doesn't complain of pain. And when we were young, we were told clamp for 4 hours initially, then you clamp for 6 hours. But I mean, if you're reasonably certain about your clearance, you could actually clamp for 24 hours. The patient doesn't have a problem. You do something called a T-tube cholangiogram, which Dr. Sinha showed you so beautifully. Ensure that there's nothing inside the bile duct, and then you take the tube out. But you must tell the patient that you are going to drain a bit of bile after that. Now, sometimes you land up with situations like that. So what will happen? You've got a huge stone, which the endoscopist was very ambitious. He said, I'm going to try and remove it Obviously, that is too big. You can see it is almost 2.5 times the size of his endoscope. There's no way you're going to be able to take that stone out, no matter how much of mechanical, laser, or whatever types of lithotripsy you have with you. So what he did was he put in a stent. Now, having put in that stent, it is now your job to go in and remove that with your cholecystectomy if you haven't done the cholecystectomy. If you've done the cholecystectomy, you will need to go in and do that operation. It's a good idea to have a stent put in. Now, the moment you have stones after a cholecystectomy, the issue is this a retained stone or is this a recurrent stone? Now, I want you to tell me what is the dictum, what is the present accepted dictum between the difference between a retained stone and a recurrent stone.
The retained CBD stone when found within 2 years of cholecystectomy.
Okay, right. So
recurrent is after 2 years.
So 48 months is absolutely right. 48 months is 2 years. So that is the, remember that term, it is 2 years. So this patient obviously needs an exploration of the bile duct, whether you do it laparoscopically or open, depends on the facilities available at your place. Okay.
Bakshi sir, I have a doubt. In the first picture which you have shown was, you told about the transcystic approach. In the before this, sir, before this one slide.
No, I didn't have any other slide before that. No pictures.
Sir,
see, I mean, I'm going to come out here. Okay. Let's take this picture. Okay. Now that is a stone which is not very big. Okay. That's the stone. Can you see the stone? Okay. So think about it. If your cystic duct is wide enough, then you could actually go in through the cystic duct, put in a Dormia basket and take out that stone. Okay. So that is a transcystic approach. Now, if unfortunately, like, life is not so clear and you have a very small cystic duct, you can't take that stone out through there. So you have to go in through a ductal approach to the bile duct.
Sir, when there are numerous stones, like more than 8 or 10 stones, we can go by a transcystic approach?
Never.
No, it is a contraindication for it.
Never. Absolute contraindication. You have a single or a double stone smaller in size, cystic duct bigger in size. So you must have stones. It has to see. There's no point in putting your hand into a jar, making a fist. And you know how people catch monkeys. You know how people catch monkeys. They have a small jar with a small enough mouth, which is enough for the monkey to put his hand in. He grabs hold of a fruit, and now he can't get the fist out. So that is the way to capture monkeys. And he doesn't have the sense enough, fortunately for people who catch them, to take that to, make his hand small and take it out again. So just remember that it is important.
Sir, why there is a separate incision for the T-tube? Why not the same incision we can use for the T-tube?
You're using the same incision for the T-tube?
The same incision?
Absolutely. I'll give you the steps of exploration of the bile duct when we come to the end. Okay? Okay? We'll come to that. So this is the way to do a intraoperative cholangiogram, and that has been modified from Gurevitch surgery. So that is you have a grasper like this. There are people who would put in the cannula and put in a clip out here. I don't like that idea because when you take that clip out, it normally tears. So this is the instrument that has been used in laparoscopy for doing a transcystic on-table cholangiogram. So that is an on-table cholangiogram. That's the technique. Okay. Now, exploration of the bile duct, you can go and see. I mean, this is, you use the endoscope is Dormia basket. So you need 3 things if you're going in for laparoscopy, either of 3 things. You either need, Alkama said a Fogarty, but I would actually suggest you use the balloon that your endoscopists use. You use so that is a balloon. You can use a Dormia basket. The Dormia basket is it's a spiral. You open it out, then you grab the stone and you take it out from here. See, this is to answer your question of a transcystic approach. That's a transcystic approach to a stone. A small stone, less number of stone, you put in a Dormia basket, grab it, and then you drag it out through the cystic duct. So your stone with the Dormia basket around it has to be less than the size of the cystic duct. Otherwise, there's no point doing it. If you're going to go for a transductal approach, again, you need a balloon, you need a Dormia, or you need a choledocoscope. Obviously, if you have a choledocoscope, there is nothing like it. And at CMRI, what we use is we try and badger our urologists to put in their flexible cystoscope and do this job for us. Okay. In a Cochrane review from 2013, 16 randomized clinical trials with a total of 1,758 patients were examined, comparing laparoscopic and open CBD exploration with ERCP in the management of CBD stones. There was no significant difference between approaches in both morbidity and mortality. So you must remember that if you're trying to stand and you are your unit uses laparoscopy and your examiner is older, who has a problem, would feel upset that you're doing a laparoscopic approach to the bile duct. You have to say that this was 2013, where a Cochrane review studied 16 RCTs, and they found that there was no significant difference between both these approaches, both in morbidity and mortality. But he also said, and this is important, that open CBD exploration was associated with a higher clearance rate. Therefore, it is mandatory for you to use all these three things. You must have a choledoscope, a Dormia, and a balloonia. Ideally, you should have all three if you're planning for a laparoscopic approach. You can't, just for the heck of it, you can't do a laparoscopic approach and then leave behind a stone. So we talk about biliary drainage procedures.
Sir, I had, sir, one question, sir.
Yeah, sure.
After putting this T-tube, and while we are doing T-tube cholangiogram, we are finding some stones.
Hang on, I think Dr. Rudrajit Sinha has a beautiful, and I'm going to ask him to show that to you. He's already shown that a beautiful plate, and I'm going to refer to that. Okay, so just hold firm. So biliary drainage procedures. What are the drainage procedures? Now, I come from a time that people used to do drainage procedures. It has, you must remember that it has become far less common. Why has it become less common? Because of the availability of endoscopic services, it has become less common. So what are the drainage procedures? Think about this, that let's say that you have, let me take this color green. Okay. And let me draw this. You have a bile duct, which is reasonably narrow. Okay. Who's going out and coming back in? I don't know why. And you have multiple stones out here, including stones right at the lower end. So what would you do? It's impacted out here. So what would you do? So what would you do? How would you approach? The bile duct isn't very dilated. It's about 8 centimeters. You've already done the cholecystectomy. Or you haven't done the cholecystectomy, you're planning for a cholecystectomy. So what would you do?
Try for ERCP, sir, and stenting.
Absolutely, please, ERCP, but that stone is impacted, Srinivas. That stone is impacted.
Endoscopic sphincterotomy.
Huh?
Endoscopic.
Okay, now I'm going to tell you. You do an endoscopic sphincterotomy. When you're doing an endoscopic sphincterotomy, that is the ampulla vater, okay? That has a fold on top. You cannot go beyond that fold, otherwise you'll create a retroperitoneal perforation. So you cut it up till here, you do a sphincterotomy. Then you do something called an endoscopic balloon dilatation. So it stretches. Okay, will you remember that? The principle nowadays is to do an endoscopic sphincterotomy followed with a endoscopic balloon dilatation. Then this particular stone, this stone might need mechanical or laser lithotripsy, and then you will be able to extract it. That is the procedure of choice nowadays. What did we do? And some of your examiners are old. Yeah, tell me.
Is there any role of transduodenal approach in this case?
That's what I'm telling you. So if your examiner is old, like me, and he is used to doing something called a transduodenal sphincteroplasty. So what is that technique? Hang on, let me just draw that again for you. So what you do out here is that you feel for the ampulla from the side, you put in, the classic description is that you put in a longitudinal incision, okay? Put in a longitudinal incision, you put in a groove direct out here, and you cut that sphincter, putting in stitches, and you take that stone out. Then you close this thing up transversely, okay? Now, this is a bit of a problem, closing it transversely, because sometimes it creates a problem. So they had something called hang on, let me get another color. Otherwise, you won't be able to find out. Let me choose, okay, orange. They had something called an incision like that. That was called a lazy S incision. So remember, that was the lazy S incision. So that had a bit of longitudinal, bit of transverse, and you did that sphincterotomy and you got out. Okay. Now, you don't need to do it nowadays because people don't do transduodenal sphincteroplasty nowadays. Okay. So remember that. So I'm going
So
to.
we should be first telling it as ERCP.
Absolutely,
and if it
no
is
question about it.
contraindicated, then we can go for transduodenal or supraduodenal choledochromy.
Jyoti, I think nowadays you would actually have most endoscopists quite competent enough to
Yeah.
handle that. You know, so these are operations which have become old. So these are the indications. Stone impacted at the distal ampullary region, multiple and recurrent CBD stones without dilatation. I'll tell you the reason why. Papillary stenosis, pyogenic cholangitis, chronic pancreatitis, and acute gallstone pancreatitis. Now, here is one place you would very rarely find surgeons handling in. You would be going over to the endoscopist for having that treatment nowadays, isn't it? So this was the incision. You did a complete cauterization. And having done a complete cauterization, you targeted this area between the upper 2/3 and the lower 1/3. Then what you did was you put in instead of a longitudinal incision, you put in a lazy S incision. I told you about that lazy S incision. You cannulated that and you cut it. I've done that. It's quite a difficult job. You keep on taking bites as you go in, and you actually end up clearing that. You can see the bites are taken in as you go in. The advantage out here is because you're taking bites, interrupted bites with monofilament PDS, it's very rarely that you have a perforation and you can have a wide enough opening. So you do that, and then you manage to take all the stones out. So that was the step, and then you ended up closing it at the longitudinal incision. You ended up closing it transversely. So that is the operation of a transduodenal sphincteroplasty. Okay, so you won't be asked. Very few people do that nowadays. So, but I thought I'd better tell you that just in case one of your examiners is fond and asks you that. We are trying to make this as comprehensive as possible. Okay, so
just few lines about supraduodenal choledochromy about that.
You're preempting all my slides, Jyoti. So this is the next page.
Okay, sir.
You're preempting all my slides. So there we are. You've done a cauterization. Okay, complete cauterization. You mobilize the first thing is you mobilize the duodenum completely. Why? Because you need access to all parts of the bile duct. Now comes the question, what are the parts of the bile duct? What are the parts of the bile duct? Your examiner says, what are the parts of the
Supraduodenal.
Hang on. It is first intrahepatic. Where's my pen? Hang on. Let me get my pen. It's intrahepatic and extrahepatic. Okay? No question about it. The extrahepatic part is divided into parts above the duodenum. So that is supraduodenal. Then you have a part behind the duodenum, that is retroduodenal. You have a part below the duodenum, which is infraduodenal. And you have a last part that goes into the pancreas and drains. That is called intrapancreatic. Now, can you imagine that unless you do a wide cauterization, you can't have access to all the areas. So you have to do that if you're going to do a proper thorough exploration of the bile duct. So having done that, you've made a longitudinal cut out here. You make a horizontal cut in the you make a longitudinal cut in the duodenum, which is actually horizontal to your previous cut. So you make a longitudinal cut out here. So when you stitch it, it becomes like a diamond. Okay. Get it? It becomes like a diamond. And you use interrupted sutures again of monofilament sutures to do that. Now, one of the criterion that had to be met, and there's a famous French term called sine qua non. So it meant that it had to be, that criteria had to be met. If that criteria isn't met, you shouldn't be doing a supraduodenal or an exploration of the bile duct. It meant that your bile duct had to be more than 1.5 centimeters. You remember I told you one of the causes of bile duct stricture is exploration of the bile duct. When you have a 7 millimeter bile duct and you explore it, the moment you close it, you can't help it. It is going to get strictured out there. So that is one of the sine qua non. That's a Latin term, a legal term that says that it had to be met. It comes from the judgments of various areas. The sine qua non had to be a 1.5 centimeter duct. Otherwise, you should not be attempting any sort of exploration of the bile duct. Okay, so what are the techniques? The other technique was a choledocojejinostomy. So you brought up a rule loop of jejunum and you stitched it out here. And again, single layered anastomosis was all right. You do it in anastomosis and you normally brought that portion of the jejunum up through a hole on the right side of the middle colic artery, taking care of the blood vessel of the transverse colon. Okay. So why choose a gastrojejinostomy? Why a cholecystogejinostomy? Now there are people who say that both, principally the choledochoduodenostomy has something which is very, very difficult to treat, and that is called a sump syndrome. Okay, a sump syndrome. What was the sump syndrome? The sump syndrome was, yeah, tell me.
So due to the remaining part of the duodenum, it causes obstruction.
No, it doesn't cause obstruction. I'm going to show. Can I just draw it out? I'll just draw it out for all of you. Just listen. Okay?
Infra-anastomotic part of the CBD, that portion, biliary sludge may
biliary sludge. Hang on, let me just draw it out for you. So what you do is you are going to, I'm going to draw the duodenum out here. Now, this is the duodenum, okay? And you've anastomosed, that is the duodenum and the stomach. Sorry? So you've done the anastomosis, it's a diamond-shaped anastomosis out here. Now what happens is they found that not just bile, you have all food material and everything collecting out here. Okay. So which is why this was the argument against a choledochoduodenostomy, because it was, when you have food, a bit trickled in out here, and that causes some syndrome. Okay. Will you remember that? So the thing was, is choledochoduodenostomy, does it cause some syndrome? Your examiners would say no, it does not cause some syndrome. But usually after choledochoduodenostomy, the ratio is 0.9%, but also very rarely reported after choledochoduodenostomy. And your examiner is going to say, what? It never happens in a choledochoduodenostomy. You would say, no, sir. When there's a very short Roux-en-Y loop has been found, there was a paper which came out in, sir, there was a paper that came out in 2011, done by a name, and that name is something that you have to quote, because everybody in India knows that name. That name comes from King's College. It's Muhammad Rela. Okay. That was Muhammad Rela's one of his earlier papers in 2011. So please remember that. Okay. Right. So we've had the sump syndrome, and I showed you how the sump syndrome, where the duct was small. Sorry, can I just go back? Where the short loop was found, food actually trickled up and went into the anastomosis. So you had the same problem on not just bile, but all food material, chewed food material collecting out there. So that was the sump syndrome. Okay, right. So towards the end, what I want to see is, number one, just keep on listening, mute your connections. So risk stratification according to Bloomgart was either high, bilirubin more than 2, alk phos more than 150, a present or recent history of jaundice and dilated CBD, and even the stone demonstrated. You would either go in for an MRCP or an endoscopic ultrasound. I grant you that, plus minus ERCP for removal. Intermediate, 1.5 to 2, alk phos 110 to 150, transaminase is more than twice normal with a remote history of jaundice and pancreatitis. Bloomgart's suggestion was do a pre-op, per-op, intraoperative cholangiogram and handle it as the situation arises. When there's a low risk with normal liver function, no ductal dilatation, no jaundice or pancreatitis, there's no need for any other imaging. You can proceed directly for surgery. Now, I'm going to give you this algorithm. Just listen to both these algorithms and we'll take all the questions later. The original algorithm was defined by the British Society of Gastroenterology in 2008. They sat down again 8 years later, 2016, but it was in 2017 that they came out with this suggestion, and I've adapted it from there. You have CBD stones with gallbladder in situ. You put the patient up for risk stratification. High, you go in for imaging. Even for medium, what we practice, we also go in for imaging. You do an MRCP or do an endoscopic ultrasound, find out whether he has a gallbladder, a common bile duct stone. If he does have a common bile duct stone, go in for an endoscopic management. It might be easy. Then you do an endoscopic sphincterotomy and a bile duct endoscopic biliary dilatation, stone extraction, and you follow up with a cholecystectomy. It has been our practice to do it 3 to 4 days post endoscopic procedure, and we'll talk about that later. If it is difficult, you go in for a mechanical or a laser lithotripsy. If it is not possible, if it's possible, fair enough, you switch back to a cholecystectomy. If it is not possible, you go in for a surgical management. The surgical management is either transcystic or transductal at laparoscopy, and I just showed you that. Now, you might have retained or recurrent stones. The cutoff point is 48 months, 2 years. You try going for a biliary sphincterotomy and a stone extraction. And if it is easy, put in a stent and then you go in for a removal of stent. If it was difficult, you go in for a mechanical, hydraulic, or a laser lithotripsy. If not possible, There are options of doing it percutaneous. If absolutely not possible, you cannot leave the patient just like that if you haven't been able to take the stone out. You've seen that huge stone, and what did the endoscopist do? He put in a stent. So you, having put in a stent, you're either going for a laparoscopic or open CBD exploration. So exploration of the CBD, first is incision. So I want you to listen out here and we take all the questions later. Right. So first is the incision, and you will say, sir, I prefer a wide, I'm used to doing open CBD exploration. I will do a wide Cocker's incision. Okay. Right. Now we've done the Cocker's incision. You've put in proper retraction and everything. The next stage is you will do an exploration and complete cockerization. So you will do an exploration and you will do a complete cockerization so that the entire bile duct is in your hands. Okay, you've done a cockerization out here. Done a cockerization, and you, sometimes very difficult because you're following in after the cholecystectomy sometimes. So you exposed it completely in your hands. Then the next stage is GB dissection and cannulation of the cystic duct for an on-table cholangiography, and we've just been through that. You must identify the bile duct, and I've seen people put an incision into the portal vein. So it is very important to do an identification of the bile duct, and to do that you take a syringe and a needle and you aspirate. When you aspirate, then you know that it is definitely bile, and sometimes the bile duct wall is fairly thick. So then after that, what you would do is you would put in stay sutures, and we've worked out why we are putting in longitudinal incisions. We've been through that already. Hang on, let me just take this. Before we put in that incision, we would actually put in 30 stay sutures on both sides, then put in that incision longitudinally. Extraction of bile duct stones and to ensure clearance. We've been through that. How do you ensure clearance? Either with a choledocoscope, or if you're using a Fogarty type catheter, which I use a size 10 Foley catheter, you put in dye through that and ensure that it is clear. So having done that, it remains, just the last thing remains is that you need to close the T-tube, either over the T-tube or primary closure, and we've been through it all. So if I take that color just to show the difference, and I will use that. So what we've done is we put in a T-tube out here, and I've shown you how to drive that T-tube. That T-tube comes out from here. You're putting in stitches, and it's a good idea to leave those stitches wide and tie all of them together so that you have a snug fit. And we've always been taught to put in the stitches on the top. Don't ask me why, but apparently if you push it towards the bottom and then you have a problem high up quite close to the hilum, that creates more of a problem. So after that, you would close up the abdomen. So these are the 7 steps of exploration of a bile duct. Okay. Right. So do we have any other questions? Then we can just, can we handle, Ramanuj, can we handle some difficult scenarios and then finish?
Sir, একটা question করব?
Sure.
Dr. Ashit বলছি স্যার।
বলো।
Hello.
বলো।
Sir, after CBD exploration, when hepaticojejunostomy is preferred over primary T-tube repair? Primary repair over T-tube, তার থেকে কখনো hepaticojejunostomy when it is preferred over the non-complicated,
for a non-complicated bile duct stones, you would never ever go in for a hepaticojejunostomy over exploration and clearance, particularly Akunka scenario. Okay, where endoscopic services are available around the clock. The only rationale, think about it. The moment you have, what are you scared about? Why are you going to do a hepaticojejunostomy? You've got a Hang on, let me take that color. You've got a bile duct like that. ঠিক আছে? ঠিক আছে? You've got,
Yes, sir.
you brought up the intestine as a Roux-en-Y loop. You've brought it up out here, stitch করেছো, এর সামনে দিয়ে কি আছে? You've got the entire colon. So now this patient, এখান থেকে এসে 45 centimeter, this is the length that you should have taken, 45 centimeters পরে আমি DJ flexure দূরে গিয়ে I've joined it up. Now this patient comes back with another stone. How are you going to tackle that? How are you going to tackle that? The only way you can tackle that is for the sonologist, for the endoscopist cannot reach. Oh, এখান থেকে যাচ্ছে, ও গিয়ে কোথায় গিয়ে পৌঁছাবে? He goes there, DJ flexure, turns around, and that is your. Wait, you think he'll be able to reach there? He won't be able to reach there. So what you have is you need a very good interventional radiologist who will come in from the top and do all you are telling him to, or you might need to re-explore. Whereas if you've got a exploration of the bile duct and you've closed up with a T-tube, it's very simple. You do a routine ERCP and take the residual stones out.
Sir, even the distal bile duct is either dilated or the stenosed,
the only
and the primary stone.
The only rationale is where you have a terminal narrowing of the bile duct. That is the reason that we would do a transection and a hepaticojejunostomy. বোঝা গেল?
Okay.
If you have a benign narrowing, I told you one of the benign causes of benign narrowing is is pancreatitis. ঠিক আছে? Okay, আমি আরেকটা difficult scenario করে দিচ্ছি.
Sir, one question, sir.
Yeah.
Sir, in which case we should directly think about going for CBD exploration without going for ERCP?
It depends on the availability of your services. Or let's say, it's good that you ask this question now. Think about this scenario. This patient is very common that you will see. This is a disease that is peculiar to Asia. This is This is called a recurrent pyogenic cholangitis, RPC. You will have heard of this. Why are we more prone to this condition called RPC? Because worms, roundworms come in, cause damage. Other bacterial infection, they cause a damage to the bile duct. You've seen the bile duct is damaged, and you've got huge stones out here. Huge stones. Not just here, you've got stones extending into the left duct. See out there. Okay, so this is a condition where what will you have to do? The treatment out here this is a difficult scenario. So what you will have to do is do a cholecystectomy. Okay, not just a cholecystectomy. You have to remove that part of the bile duct and remove that part of the bile duct. And unfortunately, because you can't leave that part of the liver behind, you have to end up doing a left hepatectomy as well. Okay, so you actually do a right duct to jejunum anastomosis. Okay, so this is one of the conditions where you would actually do a hepaticojejunostomy. Not just hepaticojejunostomy, you're going to end up doing a jejunostomy with a hepatectomy as well. Okay, the other scenario, difficult scenario that...
Speaking.
Yeah.
Sir, how would we tackle an acute attack of RPC, and would we do a biliary drainage in those conditions?
Always. If you have a cholangitis, whatever you do, Shoptik, is get a drain in and save that patient. Buy your time to go in later and treat him later. Cholangitis kills, and I've seen patients die within 24 hours of biliary sepsis. So cholangitis is one of the most frightening.
Yeah. Hello?
Yes, sir.
Yeah, Shoptik, as I've told you, and we are continuously stressing the point, is that whatever biliary disease is there, always think always think whether the patient will go to cholangitis or not.
Right, sir.
So whenever you have a cholangitis-like situation, always relieve the cholangitis before doing any definitive procedure.
Yes, sir. But is there any target level of bilirubin in RPC per se? Like we have 15 in these obstructive jaundice cases, and in some cases, I mean, like it's again classified according to Tokyo guidelines, isn't it, sir?
Yes, but what you need to do is find out his nutritional status. If you have some person with a bilirubin of 15 and he has an albumin of 3.5 and a Karnofsky staging of, reasonably doing well, then you can go ahead and do the primary operation, provided his nutrition permits you. But if he has infection, there's no question about it. Shoptik, he needs drainage, period. You save the patient first, and then you think of everything else.
Okay, and yes, sir. And will the drainage always be in an ERCP or something else?
You could do it for a PTBD also, but the problem is that, see, you've got to drain both the sides. So if you're doing a PTBD, you will need to get one tube into the left, one tube into the right, because you don't know whether there's a stone at the confluence which is preventing drainage from both sides. Okay, and ERCP has one advantage, that there's a reasonable chance the radiologist, the endoscopist might say, I can cannulate it. I've seen the dye going up to both drugs and I can put in one stent and be done with it. Okay.
Right, sir. Thank you.
Right. So the etiology is either parasitic infections of the biliary tract, ascariasis and clonotis, or malnutrition. And in the West, cystic fibrosis is a cause. Surgical treatment, cholecystectomy, stone clearance with pre-op cholangiography or cholangioscopy, biliary drainage, and plus minus possible hepatectomy. And I've just been there. It's beyond, we won't go in too far. Now, this particular patient, what do you think? This patient came in with jaundice. What do you think is wrong with this patient? Dr. Sinha touched slightly on this. Can you see that that is the stone?
Probably a case of cholangitis.
Okay, that is a stone in the gallbladder, pressing on the bile duct. There's a term called Miridze. Okay, that's a Miridze syndrome. Right, okay. ZZI, Miridze syndrome. So, Miridze classification, older classification, type 1 and type 2 without fistula, with fistula, and I'm not going to spend too much time on it, but originally described by P.L. Miridze, and you need to know that he was the father of operative cholangiography, please. So stone in the cystic duct causing obstruction of the common hepatic duct by external compression. McSherry, as he said, type 1 and type 2, but then the differential diagnosis, Klatskin tumor. I had a paper in British Journal of Surgery where we've actually studied the gallbladder for cancer, because some of these people actually had gallbladder cancer as well. So it comprises of 4 components. You must have a parallel cystic duct, and Dr. Sinha has shown you a beautiful, this is not the color that I want this color, hang on. Has shown you a beautiful anatomical curiosity where you have the gallbladder out here and it runs quite a low bit down and opens up right often to the medial side of the bile duct. Okay, so it's people like that, and when you have them having stones, sometimes you have large stones, that is when it presses on the bile duct. Okay, so one of the precepts is you have to have a parallel course of the cystic duct to the common hepatic duct. Impaction of stones in the cystic duct or the neck of the gallbladder, mechanical obstruction of the common hepatic duct by stones or by secondary inflammation and intermittent or constant jaundice and recurrent cholangitis. So you had the Sendis classification, type 1, extrinsic compression without fistula, type 2, 1/3 of CBD involved, type 3, 2/3 of CBD involved, and type 4, a complete cholecystobiliary fistula with complete circumference of the CBD involved. And if you actually compared both, that was McSherry 1, McSherry type 2 involved all this. And in short, the treatment is as follows. The treatment is that in a chronic cholecystitis, you go and do a cholecystectomy, external compression type 1, you could actually do a partial, a subtotal cholecystectomy, leaving a portion of the bile duct stuck. And we've got a fairly large series of about 10 or 11 patients that we've done where we've removed, you make a cut, remove the stone, and you stitch this up. So you end up leaving a subtotal cholecystectomy. However, if it's furthermore, what you will need to do is to make an incision. Some people actually take the stone out, take a portion of the gallbladder wall and use that as a plastic surgical operation. In other words, you leave that portion out there, that portion empty. So you bring that back and stitch it out here. Or the other option is you cut it out here and bring the portion of the jejunum up and join it out here as a sort of a cholecystogeginostomy. If it is completely damaged, and I think Oshita asked that question, if it was completely damaged, you have no other options but to go in for a complete, you complete the transection and go ahead and do a hepatocogeginostomy. Okay, so I think that's it.